using infrared meibumography, in different age groups. Dr. Mona, you are Mona. Very good. You got only 6 minutes.
Yes.
Don't exceed.
Yes.
If you exceed, mark will not be given.
Okay, sir.
Okay.
A very good morning to one and all. The title of my study is Assessment of Meibomian Gland Morphology using Infrared Meibography in Different Age Group. It was a comparative study. Now, meibomian gland is a type of sebaceous gland with tubuloacinar structure and holocrine function. It is located in both superior and inferior tarsal plates, and they secrete meibum. This meibum coats the aqueous layer and provides a tear film stability. Now, meibomian glands can be visualized by infrared light due to its property of autofluorescence of healthy meibums. So, darker regions in the meibography indicates a loss of glands, which is keratinized areas or altered meibum. In this study, we used topography based system with 875 nanometer for imaging meibomian glands in different age groups. It's a non-invasive method of imaging meibomian glands, and loss of meibomian glands lead to a decrease in lipid layer of the tear film, which in turn increase evaporation of the tear film. Now, what happens when there is increased evaporation is hyperosmolarity, inflammation and ocular surface disorders take place. This will cause discomfort, visual disruption, sensation of dry eye, and aging in individuals is accompanied with the loss of meibomian glands. Prevalence in India is higher than global prevalence, and it ranges from 18.4% to 54.3%. Now, Meibo score is a technique of actually dividing into different degrees of gland loss. That is 0, 1, 2, 3 and 4. And we have to also divide it based on clinical management, clinical assessment of the meibomian glands. That is the lid signs, express meibum and meibography. It's a combined effort. Now, the presence of dry eye disease significantly affects the quality of life by impairing routine life activity. So, age-related changes in meibomian glands play a major role in the development of dry eye disease. In this study, we assess the meibomian gland morphology in all ages. Different age-related evaporative eye disorders were also compared. Now, the aim of my study was to evaluate the morphological changes in meibomian glands associated with aging, and the objective was to evaluate the meibomian gland morphology by non-contact infrared meibography in different age group, and to find a relationship between meibography and tear film stability and tear film breakup time. It was an observational cross-sectional study, hospital-based, done in Malabar Medical College using Andes infrared topography-based meibography system. The sample size was 150, which was calculated based on a study conducted by Chatterjee S. et al. In central India. Sampling was by random sampling. Study population was from Malabar Medical College, patients with no symptoms attending the OPD from the period 2020-2021. And the inclusion criteria was any person who was attending OPD between 10 and 80 years, and patients visiting OPD for refractive errors. Exclusion criteria was if they were wearing any contact lens, if there is any known dry eye disorders or any previous history of ocular surgeries, they were excluded from the study. The data collected used in the study were obtained from the right eye of the patients, and they underwent routine slit lamp examination, any lid margin abnormality, tear film breakup time, meibomian gland impressibility and meibography. The upper and lower lids both were turned over and looked. For data analysis, we used SPSS statistics 20 and descriptive study, that is frequency, percentage, mean, and always compared. Our female population was more than males, and when we compared, we found out that age between 45 to 60 years were actually developing evaporative dry eye disorders. Similarly, there was 2% gland loss in the same age group, and when we compared age group and tear film breakup time, it was directly proportional. So it is very difficult to differentiate whether it's evaporative or aqueous deficient dry eye disorder just from our clinical management. So this study helps us to find out the exact root cause of the disease. Better than just giving, because in aqueous deficient disorders, we are giving only lubricants, while in evaporative disorders, we need to actually increase the meibum outflow by other techniques, by cold compress initially. Later on, we will go for other management. But these patients, what I selected was all asymptomatic patients. So the results showed that 16.8% of the patients of 20 to 40 years were asymptomatic. They didn't have any gland loss. But the age group of the second, that is from 40 to 60, were developing slowly. 33.6% had a second degree gland loss and 32.9% had third degree gland loss, which was from 61 to 80 age group. And the study was significant because p-value was less than 0.05. So there is an association between age and tear film breakup type, and the average loss was more in the upper lid than in the lower lid. So when we compared MEBO score and non-invasive tear film breakup time, it was directly proportional. And we have to note that with advancing age, there is meibomian gland dysfunction leading to operative dry eye. And the most, what we have to include in our day-to-day practice is that they have to undergo a meibography to differentiate the root cause. With recent advent in meibography equipments and clinical assessment, we have to differentiate aqueous from evaporative dry disorder. And in the present study, tear film breakup time was significantly shorter and abnormal with increasing age group. So to conclude, pathophysiology of dry eye need to be identified to differentiate evaporative dry from aqueous deficient dry eye for optimal management, and our study proved a strong relationship between meibography and tear film stability with advancement of age. Therefore, clinical assessment with meibography enhances the diagnosis and addressing the core pathology of the disorder. Now, the meibography machine is a part of topography machine, and it is also a part of other machines, so it is easier to undergo this test and it is cost effective. Thank you, and these are my references.
Very nice, madam. But only thing, why did you select right eye alone?
For standardizing, and our patients are not actually patients who came for checking dry eye. They are asymptomatic. So I didn't want to take their more time and make it easier for them, because I have to anyways evert the lower lid and upper lid, which might be not comfortable for each and every patient.
Achha.
They were actually coming for any presbyopic correction or any refractive error. So this dry eye is not their complaint. So I had to explain why I am doing this test. So
You done
only the shimmer test.
So what is the relevance and what is the implication of your study?
In our day-to-day OPD practice, we see a lot of dry eye, but most of them we give carboxymethyl cellulose on a regular basis, and we are not trying to find out the core pathology behind it. So they are on CMC forever, and some patients actually started asking us, okay, we know this is CMC, why should we use it? And this is not that effective. Maybe when we stop, it again comes. So that made me do the study and find out actually what is it aqueous deficient or evaporative dry eye.
Was there any difficulty in finding this dropout of the meibomian glands?
Initially, it was actually only observer based. That is, the machine shows a specific area. So if we delete some area of selection, it will give us the error value. So we, after the pilot study with 20 patients, we found out that we need to actually take the exact overlid or specify a area, which the machine normally showed. This was only the difficulty.
Next is prevalence of diabetic retinopathy. Mr. Varun.
Yes. So
Start.
good morning everyone. So type 2 diabetes mellitus is one of the most common type of diabetes mellitus and accounts for about 90% of the diabetes cases. It is estimated that nearly 8.8% of the adults have diabetes. India comes second after China with nearly 77 million diabetics, and it is projected to nearly double in the next 25 years. Diabetes is associated with a multitude of micro and macrovascular complications, and among macrovascular complications, diabetic retinopathy is one of the most common and severe complications of diabetes affecting retinal blood vessels. It has an insidious onset, and without early detection and intervention will lead to irreversible blindness. Diabetic retinopathy can develop in more than 75% of diabetics within 15 to 20 years of diagnosis, and is a leading cause of blindness among working population of the world. Estimated global prevalence of diabetic retinopathy is 34.6%. With increasing trends of diabetes, the prevalence of diabetic retinopathy is expected to increase, and the people with the risk of vision loss is expected to double by the year 2030. In Western countries, several epidemiological studies have been conducted regarding prevalence of diabetic retinopathy. It helps them to identify subgroups at risk, to meticulously plan and target health services to those at risk. Comparatively lesser number of studies have been conducted in India and especially in South India, including Kerala. Kerala, despite having high literacy and health standards, has a high prevalence of diabetes and possibly diabetic retinopathy. In a study conducted by Dr. Jalakshmi et al. In a tertiary eye care center Trivandrum, a prevalence rate of diabetic retinopathy about 14.8% was found, while in another hospital-based study, a prevalence of almost 31.5% was found by Dr. Kaushik Mani et al. Hypothesis: many diabetes mellitus patients with diabetic retinopathy is not detected at an early stage, and the prevalence of diabetic retinopathy patients in the community is higher than the existing data. Aims and objectives of the study: to estimate prevalence of diabetic retinopathy among type 2 diabetes mellitus patients, to grade diabetic retinopathy based on ETDRS classification, to study the associations of diabetic retinopathy with various risk factors. Methodology: study was conducted as a hospital-based cross-sectional study among type 2 diabetics aged between 30 to 70 years attending ophthalmology OPD of MMCRC, Calicut. After getting consent, duration was 1 year with a minimal sample size of 218. Methodology: visual acuity was measured using an illuminated logma chart. Retinal study is done using fundus camera, indirect ophthalmoscope and slit lamp biomicroscopy. Data collection was done using Proforma along with a routine screening of diabetic retinopathy without additional burden to the patient. Grading of diabetic retinopathy was done using modified ETDRS grading. Inclusion criteria was non-type 2 diabetes mellitus patients visiting ophthalmology OPD between age 30 and 70. Exclusion: any retinal media opacities. Informed consent and data analysis was done. Results: in results, it was found that a statistically significant association was found between duration of diabetes, hypertension and renal disease, while there was no statistically significant association was found with hypercholesterolemia. And this is the distribution of diabetics retinopathy among different age groups. This is the distribution of diabetic retinopathy with duration of diabetes mellitus, which shows that the maximum frequency is seen in patients of more than 20 years. Hypertension and diabetic retinopathy with renal disease, and among fundus evaluation, the mild retinopathy was seen in 10.6%, moderate 6%, severe 3.7%, very severe 1.8%, early proliferative 5%, high risk PDR 2.3%, advanced 1.4%. So total prevalence was found as 31% in the study. CSME 12.4% was seen to have CSME. Discussion: diabetes mellitus is one of the most prevalent health diseases throughout the world. Half of the individuals with diabetes mellitus can develop diabetic retinopathy with time. According to a study by Dr. T. Jalakshmi, the diabetic retinopathy prevalence was found to be 14.8. But another study by J.S. Jain found that the prevalence is among 42.9%. Other South Indian studies showed prevalence rate between 34.1 and 37%. In our study, the prevalence of diabetic retinopathy is 30.7%, which is similar to the other South Indian studies. NPDR was 22.1% and PDR was 8.7%, while 12.4% of the patients with diabetes had CSMA. Study conducted by Dr. Jalakshmi shown that there is a significant correlation between duration of diabetes, level of glycemic control, high levels of cholesterol, and no correlation with hypertension. Well, by our study, there is a highly significant association between duration of diabetes, history of hypertension, history of renal disease, but no association with hypercholesterolemia. In our opinion, it is found that there is a significant association between duration of diabetes and development of diabetic retinopathy. So early ophthalmologic screening of patients with diabetic mellitus can help in early detection and treatment of diabetic retinopathy. People should also be aware of the various risk factors associated with the development of diabetic retinopathy. So this study shows the importance of screening programs and patient education to diabetic patients to avoid the preventable blindness caused by diabetic retinopathy. Thank you.
See, this has already been proved, so many papers are there.
Yes, sir.
And this conclusion,
prevalence,
prevalence, whatever thing
sir,
is there.
but there has been.
What's the significance of conducting this study by you? Any significance? Because everyone knows that diabetic retinopathy duration and all.
Yeah, but there has been different like different studies had shown different types of like ranging from 17 to 34 percentage.
No, your significance in this part of
Yeah, it was not conducted in this area. It was especially in the Malabar area, northern Malabar area,
okay.
sir. Yes, sir. Other studies were in more in south and
what do you
central.
want to achieve? What do you want to give something advice,
Yes,
because
sir.
of your study, you want to give what advice?
Yes, sir. So whenever a diabetics, especially one with a diabetic history of more than 5 years, come to the OP of Thal OP, we should think about the diabetic retinopathy and ask the patient whether they have checked about the at least once after the detection of diabetes. And I think it should be made aware with the other department as well, because we have asked the other patients to send the diabetic patients to our department also. We have correlated with the medicine and other departments as
You
well.
have done, you have checked the fundus of all these patients? Or
Yes, sir.
everyone has.
Yes, sir.
Do you know how to read the logmar chart? Because you are told logmar chart.
Sir, it was, it is correspondingly, it was there, like,
No, that is there. You know how to read and all these things.
yes, sir, it's like,
No,
Yeah.
can you correlate Mr. Nellen's chart with logmar chart?
yeah, it is shown correspondingly, like 0.00, like that.
Ah.
It is shown along with the 6/60, the corresponding logmar chart is given in the chart. So,
That's how you know.
yes, sir.
Okay, thank you.
Yeah. Thank you.
Dr. Aisha Fahima. You are from?
Comtrust Hospital. Good morning all. I'm Aisha Fahima from Comtrust Eye Hospital. I'm here to present my research work titled A Prospective Study of Visual Outcome and Patient Tolerance of Scleral Contact Lenses. So coming to the introduction, scleral contact lenses they vault over the entire corneal surface and they rest on the sclera. The unique feature of scleral contact lens is that they have a precorneal liquid reservoir, which neutralizes the irregular astigmatism and confers a moist environment to the cornea, thus protecting from exposure to air and from the friction of blinking. The Scleral Lens Education Society classified scleral contact lenses into 3 types based on the diameter to semi-scleral, ranging diameter from 12.5 to 15 mm, mini-scleral lenses with diameter 15 to 18 mm, and large scleral lenses with diameter 18 to 25 mm. So the main indication for the use of scleral contact lenses are broadly divided into 2 categories: for vision improvement in cases of primary corneal ectasias like keratoconus, keratoglobus and pellucid margin degenerations, and secondary ectasias where there is post-refractive surgery and corneal irregularities due to injury or corneal ulcers or corneal suture scars. And the next main indication is corneal protection in cases of Stevens-Johnson syndrome, ocular cicatricial pemphigoid, etc. So the main aim and coming to the aim and objective of the study, main aim is to assess the visual outcome and patient comfort with scleral contact lenses. The objective of the study was to study the effect of scleral contact lens on vision, to study the patient comfort and acceptance of scleral contact lenses, to determine the indications of scleral contact lenses. Study design. It was a longitudinal observational study conducted at Comtrust Eye Hospital, Calicut. 24 eyes of patients fitted with scleral contact lenses were enrolled into the study. The study was carried out during the time period from January 2021 to December 2021. The inclusion criteria of the study was all patients who were prescribed with scleral contact lenses between the age group of 15 to 60 years, those patients with bullous keratopathy, conjunctival bleb, any systemic illness which prevents the contact lens wear like mental retardation, Parkinson's disease, or in conditions where IOP is not controlled were excluded from the study. Methodology. First, a detailed history and evaluation of the patient is done, including the anterior segment examination and posterior segment examination. The IOP is also recorded. The vision is recorded. Both the uncorrected visual acuity and best corrected visual acuity was recorded with a Snellen's chart, and it was later converted into logmar. Also, the near vision was also recorded. Then scleral lens trial was done on these patients, in which we assessed the fit of the lens, both the central and the peripheral fit, and the vision with scleral lenses was recorded. and patient was given a questionnaire which is based on modified NEA, National Eye Institute Visual Function Questionnaire 25 questionnaire, which assesses the subjective evaluation of the patient, subjective difficulties of the patient without any correction or with the impaired vision. Next is customized scleral lens is ordered, and the patients were followed up after a period of 3 months, in which we record the vision with scleral contact lenses, the number of hours per day the patient is wearing the scleral contact lens, any complications with the use of scleral contact lens, and the subjective analysis is rechecked with the use of scleral contact lens. Coming to the results and discussion, we found that the main indication of scleral contact lens was in keratoconus patients. Almost 75% of the patients who had prescribed the scleral contact lens were keratoconus patients post C3R, and 16.7% of the patients had advanced keratoconus, and 4.2% of the patients had central corneal scar, and 4.2% was post penetrating keratoplasty. This was found in agreement with the study by Pulam et al., which showed the major indication for scleral contact lens was keratoconus or other primary corneal ectasias, followed by corneal transplant in 18.6%, followed by ocular surface discomfort in 11.4% of the patient. Also, Weiser et al. Study also showed that the major indication for scleral contact lens use was keratoconus, followed by post-penetrating keratoplasty, and other indications were irregular astigmatism due to scars, keratitis, trauma and irradiation. Now the visual outcome, we found that the baseline visual outcome of visual acuity of these patients in logMAR was 1.04 plus or minus 0.53, and this improved to a value of 0.27 plus or minus 0.21 at the 3 months with the use of scleral contact lens, and this showed this was statistically significant. The results were in agreement with the study by Preeti et al., which showed an improvement of vision from logMAR 0.59 plus or minus 0.32 to improvement with scleral contact lens to a value of 0.24 plus or minus 0.19, and Low et al. Also showed an improvement of BCVA in logMAR from 0.71 plus or minus 0.5 to 0.05 to plus or minus 0.07. The study also showed that there is improvement of the near vision to N6 from the baseline value of less than N36 in majority of the patient. The subjective analysis was done in 4 domains: social function, role difficulties, dependency, and mental health. The social function value showed an improvement from the baseline value of 16.04 plus or minus 2.53 to a value of 7.92 plus or minus 1.53 with the use of scleral contact lens at the end of 3 months. The role difficulty domain also showed an improvement from the baseline score of 4 to a baseline to the score of 2 at the end of 3 months. The dependency domain also showed an improvement from value of 2 to a value of 1 in majority of the cases, and the mental health domain also showed an improvement of value from the score of 2 to score of 1 in 95.8% cases. This was in accordance with the study by Preeti et al. And Weiser et al. And Abu-Samara et al., which showed then a significant degree of comfort with the use of scleral contact lens. The duration of use was found to be 6 to 7 hours per day in majority of the cases, followed by 8 to 9 hours per day in 25% of the cases. And none of the patients reported any infectious complication, while 87.5% did not report any complication. 8.3% of the patients reported occasional dryness, and 4.2% had complaints of occasional itching. And this was in the study by Abu-Samara showed complications like allergies, tight lens syndrome, dry eye syndrome, broken lenses, and lens scratches, SPKs with the use of scleral contact lens. So, in order to conclude, the scleral contact lens provide optical correction in patients with irregular corneas due to various conditions like corneal ectasia, post-penetrating keratoplasty, corneal scars due to trauma or other infections. Significant improvement of both vision and quality of life of the patients was noted. The patient should be reviewed to look for any complications related to the scleral contact lens use. A steep learning curve is required for the self-installation of scleral contact lenses. Thank you.
I think we have exceeded the time also. So you are supposed to have finished within 6 minutes. Okay, but you were told about something scar, no? In scar, how the vision can, which you told central scar.
Yes.
So scleral contact, what for you have applied scleral contact lens?
The scleral contact lens, they minimize the light scattering due to the presence of precorneal liquid reservoir between the lens, and the patient had improvement of vision, though not up to 6.6 and N6. Patient
Suppose I am having a leucoma in front of the pupillary area, it's a central area. We have applied scleral contact, will it improve?
No, we have to at least a pupillar, some part of the pupil should be spared with a
Because you have
scar.
told generally central scar.
Yes.
You have not mentioned whether it is covering the pupil or away.
Yes.
Okay, thank you.
Okay, again I wanted to ask that same question. What was the indication of using that scleral contact lens in a central corneal opacity? You said specifically it is a central corneal opacity. Was there any improvement of vision in that case?
Yeah, the patient had central corneal opacity. The patient had scar due to trauma and following the surgery, and the patient had improvement up to 636. Though the near vision was not improved, the near vision was less than N36.
So maybe some part of the pupillary area was clear.
Some part of the pupil should be spared.
Okay. What was the diameter of the lens used in all cases? Same diameter or different?
In most of the cases, we ordered the semi-scleral lenses, but when the fitting is not correct for the patient, we have to move for the lens with have more landing zones.
Now, Dr. Ann Reshma Rajan, retinal changes in anemia.
Good morning, respected judges and other delegates. The topic of my paper is Retinal Changes in Anemia, a comparative cross-sectional study using SDOCT. My name is Dr. Ann Reshma. I am from Jubilee Mission Medical College, Thrissur. Coming to introduction, World Health Organization defines anemia as hemoglobin levels less than 12 gram per deciliter in women and less than 13 gram per deciliter in men. According to ICMR, in pregnancy, hemoglobin is less than 11 gram per deciliter supposed to be anemic. The public importance of anemia is because of the high burden of anemia which is seen in our community and also associated increased morbidity. Coming to the broad causes of anemia, nutritional causes are the most common, anemia of chronic diseases or unexplained anemia, out of which the most common is iron deficiency anemia. Since iron is the major oxygen transporter in the body, iron deficiency causes enhancement of effects of ischemia, and that affects the eye also and causes anemic retinopathy. Retinal ischemia causes hypoxia, and inner retinal layers are found to be most susceptible to damage. And neuronal cell death, ganglion cell damage, and as seen in the figure, superficial and deep retinal hemorrhages, cotton wool spots, etc. may be seen. Coming to my study, aims and objectives: to categorize the patients with anemia into mild, moderate and severe anemia and study the changes in each category, and to study the retinal changes by SDOCT, and two parameters are mainly noted, that is the peripapillary retinal nerve fiber layer thickness as well as the vertical cup disc ratio. This was a comparative cross-sectional study which setting was in various clinical departments and the Department of Ophthalmology in a tertiary healthcare center in Kerala. Sample size comes to 15 in each test and control group, that is a total of 30 eyes in each group. Inclusion criteria: all adult male and female patients between 18 and 60 years of age were included, and anemic patients were included in the test group and non-anemic patients were included in the control group, and OCT signal strength of more than 6 out of 10. Exclusion criteria: pre-existing ocular diseases, diabetic or hypertensive retinopathy, systemic diseases with ocular manifestations, pregnancy, malignancy and chemotherapy-induced anemia, gross opacity of optical media, glaucoma cases, patients on drugs that can affect the retinal thickness, previous intraocular refractive surgeries or laser therapies, history of ocular trauma, and high refractive errors were excluded. Coming to my methodology, the patients were selected based on these criteria, 15 in each group, and then the relevant test for anemia workup was done. And finally, this patients were undergone detailed history and evaluation, ophthalmic examination, And then they were classified into mild, moderate, and severe anemia based on WHO classification. Then they were subjected to OCT, ONH, and RNFL thickness and vertical cup disc ratio were noted. This was the WHO classification which was used in my study. Coming to observations, in the test group, that is the anemic patients group, 80% of the anemic patients were found to be females. That points to the increased prevalence of anemia among females. Whereas the male-female ratio is almost equal in the control group. In the anemic group, majority belong to the moderate anemia category, that is 66.6%, and the average ages of patient were comparable in both the groups. Mean intraocular pressure were comparable in both the groups, and any sort of visual complaints were present in 6 anemic patients, that is 40% of the cases, out of which reduced vision was a major complaint. And anemic retinopathy finding, that is severe anemic retinopathy finding, was present in only one patient, that is 6.6% with a severe anemia, and that included bilateral retinal hemorrhages and cotton wool spots. The average RNFL thickness was comparable. As you can see in the figure, we found that the superior and inferior quadrant RNFL was thinner in the anemic group, but the p-value was not significant. But the temporal quadrant RNFL was significantly thinner in the anemic group than the control group. This was the average vertical cup disc ratio. It was found to be significantly increased in the anemic group compared to the control group. This was a normal OCT and the abnormal OCT in patients in an anemic patient. Coming to discussion, our study showed that the temporal RNFL was significantly thinner and vertical cup disc ratio was significantly increased in anemic patients. So decreased RNFL or an increased cup disc ratio may point to various types of retinal ischemic diseases, or maybe a treatment of glaucoma. It can have an impact. IPEC et al. Have compared females with iron deficiency anemia and controls and found that the average RNFL was thinner in anemic group with a significant p-value, which was corresponding to our study. Onsel et al. Also found a significantly thinner RNFL in the nasal inferior quadrant. KSOS et al. Found that the lower RNFL thickness in the inferior quadrant in iron deficiency anemia, whereas thalassemia patients showed all 4 quadrant thinning of RNFL. Semavi et al. Also found out a similar result. And also in that case, the cup disc ratio was increased in patients with thalassemia. So temporal quadrant RNFL thinning and increased vertical cup disc ratio were significant in our study. Hence, these parameters may be used to detect early pathology. Hence, the need for screening, early detection, and prompt treatment of anemia to prevent complications of anemic retinopathy. Advantages of our study: all causes of anemia were taken into account, anemic workup was done. Limitations included undocumented duration of anemia and smaller sample size. These were my references. Thank you.
Okay, very nice. But why that's a tendency for temporal quadrant of the retina as well as the vertical CD, you told, increased?
Yes, sir.
What about the arcuate zone? You have seen the fundus, the OCT. Any problem in the arcuate zone and all?
No, sir. The temporal quadrant RNFL
you told vertical cup disc ratio is increased. That means the
increased.
vertical means the arcuate fibers entering superior and inferior,
Yes.
they should have got damaged.
Damage.
That means that ganglions also should have been damaged.
Yes, sir.
You told generally temporal. Temporal means entire temporal.
Temporal was significantly found in our study.
Any reason?
Sir,
Because why you have told other fellows have given all the quadrants
yes,
in thalassemia.
inferior and nasal quadrant is most.
But why
seen.
in your study did you find out any reason for that?
No, sir. In my study it was temporal, but in other studies usually inferior and nasal field were considered.
Why there is a temporal retina is predilection for this? Any vascular supply, because you told vertical CD is increased.
Yes.
That may be because of vascularity, that also because of anemia only.
Yes, sir. Because of anemia. Because all other conditions were ruled out. All other vascular diseases or diabetic or hypertensive retinopathy were ruled out, and only patients with anemia were taken into the list.
Any significant white-centered hemorrhage you have seen? No.
In one patient, there was significant superficial and deep retinal hemorrhages and cotton wool spots in patient with severe anemia. He had a hemoglobin of 3.
Roth spots. You know
No,
Roth spots?
Roth spots were not seen, sir. Deep and superficial hemorrhages were seen, and he was sent for further workup.
Okay, thank you.
What was the cause for decreased visual acuity in 5 or 6 patients?
Yes, ma'am.
Was it the anemia the reason for that visual acuity?
So there might be an incipient cataract
Only one
also.
patient had anemic
Yes,
retinopathy.
only one patient had severe anemic retinopathy findings, but majority of the patients with decreased vision had some sort of changes in the RNFL and cup disc ratio also. So there might be some
correction of anemia will
Yes.
improve the retinal nerve fiber layer thickness.
Yes, ma'am. I think early detection and maybe prompt management can prevent further complications of anemic retinopathy.
Yes, those with decreased vision, have you assessed the refractive status?
Yes, ma'am.
It's not improving?
No, not improving.
Next is Dr. Meera Nayar. In preterm infants with retinopathy, long-term refractive outcomes. You are from which place?
Sorry, sir.
You are from which college?
Good morning. My study is on the long-term refractive outcomes in preterm infants with retinopathy of prematurity. Treatment modalities in ROP have changed over years. We have started from the cryotherapy, we have moved on to laser photocoagulation, intravitreal anti-VEGF, and combined intravitreal of anti-VEGF and laser photocoagulation in selected cases. Very few studies have compared the long-term refractive outcomes of each of these treatment modalities. Objective of my study is to compare the refractive outcome of preterm infants treated with anti-VEGF monotherapy versus laser photocoagulation versus combined anti-VEGF and laser photocoagulation versus spontaneously regressed ROP in a tertiary eye clinic. My study is a retrospective cohort study from a period of June 2020 to May 2022. Eyes of premature infants with retinopathy of prematurity diagnosed between 2016 and 2018 were included in my study. 72 eyes of 36 patients were included in my study. So for the purpose of the study, we have divided the infants into 4 groups, that is, based on the treatment they received, into group 1 having anti-VEGF injection alone, group 2 having laser photocoagulation alone, group 3 having anti-VEGF and laser photocoagulation, that is combined therapy, and group 4 having spontaneously regressed ROP without any treatment. So based on the ETROP guidelines as well as the stage and severity of the ROP, we have planned the treatment modalities, and following treatments were given, that is anti-VEGF with laser or laser photocoagulation alone, or no treatment in case of spontaneously regressed stage 1 or stage 2 disease. Anti-VEGF injections were not repeated in any of the patient in any eye, and these children were followed up annually with cycloplegic refraction and fundus examination. Longitudinal cycloplegic refraction were measured at each visit prospectively, and refractive error was recorded in the form of spherical equivalent. We have classified these infants based on the refractive error according to the literature into low myopia, high myopia, emmetropia, and astigmatism. The uncorrected visual acuity was measured with age-appropriate pediatric visual acuity charts in younger children and were converted into logMAR. Infants who had other congenital systemic or ocular abnormalities and infants who lost follow-up were excluded from the study. Statistical analysis was done using SPSS version 20. Coming to the results, 64% of the infants in my study group were male and 36% were females, and the other chart shows the distribution of males and females among the 4 groups. Mean gestational age of infants in the study group was 28.5 with a standard deviation of 3.83. Coming to the distribution of birth weight, there was a significant difference in the distribution of birth weight among the 4 groups with a p-value of 0.007, and spontaneous regression group had a highest mean birth weight. We also looked into the distribution of uncorrected visual acuity among the 4 study groups, and it was noted that infants treated with intravitreal anti-VEGF alone had a poor uncorrected visual acuity. Coming to the difference in the spherical equivalent among the 4 groups, it was noted that the anti-VEGF group had the highest spherical equivalent and spontaneous regression group having the lowest spherical equivalent. And we did a pairwise comparison among the 4 groups, and between the anti-VEGF and the spontaneous regression group, there was a significant difference with a p-value of 0.05. We also categorized the infants based on this refractive outcome into low myopia, high myopia, emmetropia, and we noted that high myopia was found to be more in the anti-VEGF alone group, followed by the anti-VEGF and the laser group, and there was no instance of high myopia in spontaneous regression group and highest amount of emmetropes in the spontaneous regression group. Also, the astigmatism was found to be highest in the anti-VEGF alone group, and it was lowest in the spontaneous regression group. We took the myopes among the 4 groups, and when we looked at the myopes among the 4 groups, it was noted that the injection combined group was having a higher spherical equivalent, and astigmatism was more in the injection alone group. We also looked into the association of various risk factors with the incidence of myopia, and it was noted that the multiple pregnancy, mechanical ventilation, ventilation, history of sepsis, they were not found to have any statistical significance with the incidence of myopia. Also, the zone of ROP was not found to be significant with the incidence of myopia. Mean gestational age was also not statistically significant with the incidence of myopia, whereas mean birth weight, the incidence of myopia in infants with low birth weight was found to be statistically significant. We also looked into the stage and the incidence of myopia, and higher the stage of ROP, more was the myopia with a statistical significance of 0.004. Coming to the discussion, myopia associated with ROP have been studied since early 1950s, and Becher and Brandon were the first to analyze the ROP and myopia, and they postulated that it could be the underlying metabolic disturbance that is causing the change in the refractive component. Other postulates were the forward lens position, incomplete postnatal development of the crystalline lens, as well as retina being orchestrating the overall ocular growth and development. It can affect the scleral and corneal maturation, which will be affected in a premature retina. So in our study, we have noted that the stage of ROP and the amount of resultant myopia had a significant correlation. Zacharias and associate also have proved the same. And with the advent of anti-VEGF, it was thought that the incidence of myopia will be reduced when the infants were treated with anti-VEGF, but it was other recent studies have shown that it is not true. In our study also, we noted that the myopia was higher in the anti-VEGF and combined anti-VEGF and laser group. Chen et al. Has postulated that the inhibition of VEGF by the anti-VEGF may induce more apoptosis in the peripheral retina and subsequent dysregulation of emmetropization. So we compared our study with the other international study, and we noted that in our study, there was a similar incidence of myopia in our studies as well as Castellanos et al. Study, but in Chen et al. Study, the incidence of myopia was lesser. When we compared the infants treated with laser group, there was higher incidence of myopia in the other groups when compared to other study. This can be due to the diode laser used in their study and double frequency NDI laser used in our study. Also in the combined group also, there was a comparative result, but the incidence of myopia was more in the injection group in our study. Limitation of study, we have not measured the parameters like corneal curvature, structural parameters because of the uncooperativeness of the patient, which would have given us more structural information. So to conclude, in our study, we have a higher incidence of myopia in infants treated with anti-VEGF as well as the combined therapy. We also noted that there was a significant association between stage of ROP and myopia, and also as well as the mean gestational age and myopia. This suggests that prematurity itself, and higher the stage of ROP, more chance child developing myopia, and the treatment modalities may not be the only factor affecting the presence of myopia in these children on long-term follow-up. These are my references. Thank you for the patient listening.
Very nice presentation, but
Thank
the
you,
problem, you told now spontaneous regression, you have observed some patients.
Yes, sir.
Which are the stage of ROP was
Stage
what?
1 and stage 2, sir, which have spontaneously regressed, sir, without any treatment.
Did they did have a plus sign or
No,
not?
sir. No signs of plus disease.
Achha.
Yes, sir.
Then you are told anti-VEGF can go in for myopia.
Yes, sir.
And you told something apoptosis. What's the rationale if that's combining? That
Sir,
apoptosis
in the study by Chen et al., they have found that the suppression of the anti-VEGF, suppression of the VEGF by the anti-VEGF was causing this apoptosis of the peripheral retina, which can be the cause of dysregulation of emmetropization.
What do you mean by that?
Because the retinal factors are the one which is contributing to the process of emmetropization. That is, several theories are there, sir. So, such as for the overall ocular development, for the structural development of the eye, we need factors from the retina. So, this is not happening in cases of premature retina. So, the anti-VEGF suppression, the VEGF suppression by the anti-VEGF may be causing that depression in that ocular factors which are needed for the normal maturation of the retina, normal maturation of the overall eye.
You are giving anti-VEGF because the patient has developed a prematurity.
Yes, sir.
If you allow it, then the patient may lose the vision.
Yes, sir.
That's why I've tried, no?
Yes, sir. But that may be the reason is what they are telling in the study, sir. We have also found that the incidence of myopia
What
was...
the dose of anti-VEGF you have given?
Sir, 0.05, sir.
0.05, what anti-VEGF?
We have some patients, almost 2-3 patients are having Avastin, and rest of the patients were ranibizumab, sir.
Ranibizumab.
Yes, sir.
The dose is same for both?
Yes, sir.
Dose?
Yeah. 0.1 mg per ml of ranibizumab and 0.05 ml of bevacizumab, sir.
Okay.
Only one injection was given.
Okay. Only one injection per patient, sir. No,
So
it was not.
Finally, do you think the incidence of myopia is due to the treatment or due to the prematurity or due to the severity?
It is not
Finally,
due to
what
the
is
treatment
your
modality, because in cases of infants receiving anti-VEGF injection, the severity of the disease was more. In zone 1, it will be in the zone 1 or zone 2 posterior. So it is because of that severity of ROP that is causing the myopia, resultant myopia, not the treatment modality. Thank you.
Now, Dr. Namita Suresh Kumar.
Morning all. My topic is correlation of disc damage likelihood score with average RNFL thickness determined by OCT and visual field globulin disease in established cases of primary open-angle glaucoma.
Hello, time start. Time.
Introduction. Glaucoma manifests clinically as a loss of optic disc neuronal rim tissue, RNFL defects and visual field defects. Traditionally, vertical CD ratio is used to evaluate the optic nerve changes. The CD ratio does not take into consideration the diameter of optic disc or focal changes in neuroretinal rim. The disc damage likelihood scale is a system that incorporates disc size and rim disc ratio in the clinical grading of disc. It is useful in diagnosis as well as for assessing the severity of glaucoma, and as a standalone test, RNFL analysis has great diagnostic ability to detect early pre-perimetric glaucoma, and in perimetric diseases, RNFL loss with a corresponding visual field change is helpful in confirming glaucoma. A mean deviation and pattern standard deviation of global indices, which gives a numerical quantification of visual field loss in decibel. The aim of our study was to determine the correlation between DDLS with average RNFL thickness in OCT and visual field global indices, that is mean deviation, pattern standard deviation, established cases of primary open-angle glaucoma. Study design was a cross-section study. Study period from January 2021 to June 2022. Study populations, patients attending the OPD and diagnosed as having primary open-angle glaucoma. Sample size was 60. Inclusion criteria: all diagnostic cases of primary open-angle glaucoma with best corrected vision more than 660 in versi, an age in between 40 to 80 years and reliable automated perimetry. Exclusion criteria: other ocular diseases associated with raised IOP, cloudy media impairing fundus examination, and history of intraocular surgeries within last 3 months. Study procedure: patients with POG satisfying inclusion-exclusion criteria were enrolled into the study after getting an informed consent. Brief biodata and history were taken, and all subjects underwent complete ophthalmological assessment, including visual acuity, refraction, slit lamp examination, IOP measurement, Goldman applanation tonometry, and gonioscopy. Visual field charting using HFA CETA standard 24-2 program. An average RNFL thickness assessment with calci spectral domain OCT. The fundus was examined using a 90D walk lens and slit lamp, and DDLS score was calculated. Result: the mean age group was 60.2 with a standard deviation of 9.38. Among the subjects, 33% were males and 6.7% were females. Average RNFL thickness was 73.48 with a standard deviation of 14.91. Average DDLS score was 5.33 with a standard deviation of 1.26. Average visual field index was 82.8 with a standard deviation of this is a scatter plot diagram with DDLS score along the x-axis and average RNFL thickness along the y-axis. As the DDLS score increases, average RNFL thickness decreases. The Karl-Pearson correlation coefficient between the two parameters were minus 0.630 with a p-value of less than 0.01, which corresponds to a highly negative correlation between the parameters. This is a scatter plot diagram with DDLS score along the x-axis and mean deviation along the y-axis. As the DDLS score increases, mean deviation decreases. The correlation coefficient was minus 0.662 with a p-value of less than 0.01, denoting a highly negative correlation between parameters. This is a scatter plot diagram with DDLS score along x-axis and PST along y-axis. As the DDLS score increases, PST also increases. The correlation coefficient was 0.564 with a p-value less than 0.01, corresponding to a moderately positive correlation. Correlation of average RNFL thickness with mean deviation, the coefficient was 0.617 with a p-value of less than 0.01, corresponding to a highly positive correlation. And correlation of average RNFL thickness with PST, the correlation coefficient was minus 0.447 with a p-value of less than 0.01, corresponding to a moderately negative correlation. Discussion from the study: we found a strong negative correlation of DDLS with average RNFL thickness and mean deviation, and a moderate positive correlation with PST. And the average RNFL thickness is showing high positive correlation with mean deviation and moderate negative correlation with PST. Comparative study of two methods of optic disc evaluation in patients with glaucoma by Chandra et al. Demonstrated that DDL showed a strong positive correlation with mean deviation and a strong negative correlation with RNFL thickness and a weak positive correlation with PST. In a study with Narayana et al., comparing vertical cup disc ratio with DDLS score with visual field indices, DDLS showed a strong correlation with mean deviation and PST. Conclusion, we found a strong negative correlation of DDLS with average RNFL thickness and mean deviation and a moderate positive correlation with PST. Average RNFL thickness is showing high negative correlation with mean deviation and a moderate negative correlation with PST. Thus, DDLS score is a good indicator of optic nerve head status and has good correlation with average RNFL thickness and visual field index in POAG. Limitations of the study, DDLS used in the study is a clinical scale and it is subjective and can vary with observer, and it does not document progression in more than one region in cases of multiple areas of focal thinning. These are my references. Thank you.
So you have not shown any OCT picture compared with the NDLs and all. See, only when you show some picture which has got some DDLS, the changes only corresponding OCT picture, so that you can assess. When you have not shown that, just reading may not be useful, no? You should have taken some photographs. That is my opinion, okay?
So what do you think is the advantage of DDLS score compared to CD ratio?
Ma'am, DDLS is a clinical score and it incorporates the disc size as well as the focal narrowing of rim disc when compared to the CD ratio.
So what is the limitation when you are comparing the focal notch alone and the rim tissue? What is the limitation?
When there is multiple focal narrowing, DDLS is not useful.
Dr. Sri Lakshmi Prasant.
Sri Lakshmi Prasant.
Good morning, everyone. Diabetic retinopathy is the leading cause of vision loss in the world today. Numerous choroidal vascular abnormalities have been reported in patients with diabetes mellitus. So today, I, Dr. Sri Lakshmi, am here to present my study on the topic changes in choroidal parameters in patients with type 2 diabetes mellitus. Choroidal vasculature, mainly choriocapillaries, supplies nutrients and oxygens to the outer retinal layer, retinal pigment epithelium, and the photoreceptors in the foveal region, mainly where there is no retinal vasculature. So it states that choroidal blood flow in the foveal region becomes slower in patients with type 2 diabetes mellitus, which can result in choroidal hypoxia, which leads to thinning. In my study, I was aiming to expect the value of mean subfoveal choroidal thickness, mean nasal and temporal parafoveal choroidal thickness, and the mean choroidal vascularity index in patients with diabetic retinopathy and with patients with no diabetic retinopathy, and also how these parameters are affecting according to the severity of the disease. So I did this study as a prospective cross-sectional study in the patients attending ophthalmology OPD and patients with type 2 diabetes mellitus of more than 5 years of duration and between the age group of 35 to 75 years, and 72 eyes of 72 patients were taken into consideration. And eyes with a refractive error of more than or equal to plus or minus 3 diopter, eyes with previous history of retinal surgeries, previous history of lasers, eyes with already existing retinal disorders including retinal vein occlusions, ARMD or glaucoma, these were excluded from the study. And detailed ophthalmological examination were done for every patient, including an extended depth OCT was taken, and patients were grouped according to group 1 with diabetic retinopathy and group 2 without diabetic retinopathy. And again, this group 1 with diabetic retinopathy was divided according to the severity of the disease. And the study parameters were recorded, and from an extended depth OCT, a vertical distance between the hyperreflective Bruch's membrane to the hyperreflective choroidoscleral interface was taken as the subfoveal choroidal thickness, and the same vertical distance was taken at the nasal and temporal gradient with 1.6 millimeter at the foveal center as the parafoveal choroidal thickness. To calculating the choroidal vascularity index, we created a algorithm for image binarization, and from a grayscale OCT image, after image binarization, we got a binarized OCT image. And a 1.5 millimeter segmentation block of the subfoveal choroidal area was selected as the region of interest, and the total subfoveal circumscribed choroidal area was calculated with total number of dark pixels as well as light pixels, and total luminal area was calculated as the total number of dark pixels. Then the ratio between the choroidal luminal area and the total subfoveal choroidal area was calculated as the choroidal vascularity index. And these data were entered, and the statistical analysis was done, and p-value of less than 0.05 was considered as statistically significant. And from the results, 72 eyes of 72 patients, 32 were of females and 40 were of males. 60 out of that were with diabetic retinopathy and 12 without diabetic retinopathy. And after that, the result we got was the subfoveal choroidal thickness, parafoveal choroidal thickness, both nasal and temporal, was significantly reduced in group 1 with diabetic retinopathy when compared with the group 2 without diabetic retinopathy. And the significant difference was also noted, that is, significant reduction was also noted in the choroidal vascularity index with diabetic retinopathy, that is in group 1, when compared with the group 2. So what, according to the severity of the disease, from no diabetic retinopathy to the proliferative diabetic retinopathy, the thickness was decreasing. That is, the significant thinning was noted. And the choroidal vascularity index was also reducing. That is, significant reduction was seen. That all the study parameters were significantly reduced according to the increase in severity of diabetic retinopathy. So, the similar results with subfoveal choroidal thickness thinning was noticed in other studies also, especially the one done by Sudhagar et al. In an Indian population, but contradictory result of thickening was noticed in other study done in Korean population by Kim et al. And the choroidal vascularity index was significantly reducing in other studies also in patients with type 2 diabetes mellitus. So, in conclusion, the choroidal blood flow deficit can be an early pathologic change in diabetes mellitus. So, in patients with diabetes mellitus, these alteration in these choroidal parameters may indicate the role of vascular change in choroid in the development and prognosis of diabetic retinopathy. So detection of this thing, that these can be considered as the earliest marker, and so that we can knock out the leadership, like knock out the position of diabetic retinopathy from the leading cause of blindness in the vision loss today. So that's all from my side. Thank you. These are my references.
Very good, but
yes, sir.
You're told that choroidal, that is thinning of the vascularity in the choroid.
Yes, sir.
Is the most important. It's the earliest finding.
It was, yes, sir.
Suppose clinically I cannot see, that. So only we need a OCT.
Yes, sir, OCT. Clinically, no, sir. By OCT. By OCT.
Suppose OCT you are seeing, the same patient had any microaneurysms or not?
Yes, sir. We also did the fundus examination. After that, only we did the OCT.
Then microaneurysm was seen before doing OCT or after only you have found out?
So before doing OCT. First fundus examination was done, and after that patient was categorized, then we did an OCT.
Which is the earliest finding then?
So actually,
How can you say that choroidal vascularity is the earliest finding problems? You mentioned that earliest finding. But you told microaneurysm was present before itself.
Sir, my purpose of my study was in a country like India with so much population, around 1.4 billion population. So only few ophthalmologists are here. So these are OCT and other things are made for an artificial intelligence or a machine related thing. So we can't go and diagnose these things in every patient. So if we create a universal user interface, so that we can take things like this, and so I think that.
Then you can advise OCT for all the diabetic patients, enter your OP. Is it possible?
Actually, for cost related thing.
Earliest finding.
Yes, sir.
Earliest sign is choroidal vascularity.
Yes, sir.
So if you start doing from the beginning, why can't you find out early so that you can control diabetes and all? No? At least
it's possible, sir. It's possible. we can go for that. Maybe after a few times, may the cost reduction is there, we can advise it for every patient because there is no other risk factor
See, the
in doing.
microaneurysm.
Yes, sir.
If it is very small, so you cannot detect. At least it needs some size of 20 microns.
Yes, sir.
So that suppose what you have seen microaneurysm, maybe more than 20 microns.
Yes, sir.
If it is less than that, you may not find.
So finding microaneurysm depends on the doctor who examined the fundus. So if someone is not able to pick something, otherwise the machine can pick it up. So this is a one-click result. So these things are to be considered in this era.
Did you find any confounders that affect the choroidal thickness in these patients?
Ma'am, actually, even hypertension.
Yeah, all these can affect.
Yes, ma'am.
So that was excluded or?
Hypertension was not excluded, ma'am. It was not excluded.
Presentation is evaluation of ocular surface disease and quality of life in glaucoma patients. Glaucoma is a chronic progressive optic neuropathy characterized by typical optic disc changes and retinal nerve fiber layer changes with associated visual field defects. The first line therapy is medical therapy, where anti-glaucoma medications are used, and benzyl alkonium chloride, BAC, is a preservative that contributes to ocular surface disease by causing tear film instability. It has a well-known dose-dependent toxicity. Ocular surface disease index is a 12-item questionnaire which is used for rapid assessment of ocular surface disease. Glaucoma quality of life 15. It is a 15-item questionnaire where the patient can evaluate their ability to perform visually demanding tasks in daily life. The aim of the study is to investigate the relationship between topical anti-glaucoma therapy, ocular surface disease, and quality of life in glaucoma patients. The methodology used was a cross-sectional comparative study from November 2019 to September 2021, and the sample size for the study was 85. The inclusion criteria was all participants were 40 years or older, and in the control group, patients are glaucoma suspect without any visual field loss. They had a normal intraocular pressure and they were not on topical therapy. In the case group, they were diagnosed as having primary open-angle glaucoma, and they were on topical anti-glaucoma therapy for at least a period of 3 months. The exclusion criteria was patients with visual field defect due to non-glaucomatous conditions, laser treatment or filtration surgery in the past 3 months, patients with prior ocular surface disease prior to starting glaucoma therapy, patients with secondary glaucoma, angle closure glaucoma, and lid abnormalities such as entropion, ectropion. Assessment was done with best corrected visual acuity using Snellen chart, which was converted to logMAR. Intraocular pressure was measured. Fundus and disc evaluation was done with slit lamp biomicroscopy. HFA 24-2 CETA standard was done. Detailed drug history, considering the number of drugs, the type of the drug, the duration of use, and the number of BAC drops per day was noted. Ocular surface disease was evaluated using TBUT, Schirmer test 1, corneal staining, and the questionnaire used was OSDI and GQL15. Glaucoma patients were classified according to glaucoma staging system into 3 groups based on the loss of visual field as mild, moderate, and severe. The tear breakup time was normal if it was more than or equal to 10 seconds and severe if it was less than 5 seconds. Corneal fluorescent staining was normal if there were 0 dry spots, mild if there were 1 to 2 dry spots, moderate if there were 3 and 4, severe if it was more than 4 dry spots. Schirmer test was normal if it was more than or equal to 10 millimeters and severe if it was less than 5 millimeters. This was the OSDI questionnaire given. It was 12 questions and the total score is out of 100. If it is normal if the score was between 0 to 12, mild 13 to 22, moderate 23 to 32, and severe if the score was more than or equal to 33. Glaucoma quality of life 15, it has 15 questions, the total score was 75, and as the score was higher, it implied that there was a poor quality of life. Coming to the results, the mean age among the participants was 58.6 and the range was 40 to 89. The gender distribution in my study was equal. The distribution of glaucoma patients in my study, 29.1% were from moderate glaucoma. The mean value of TBUT and Schirmer was lower with higher corneal staining values in cases. And distribution of glaucoma patients according to the anti-glaucoma medicine, approximately 50% they were on prostaglandin analogs, followed by beta blockers. Correlation between OSDI and GQL15, there was a high and strong positive correlation between both, suggesting a poorer quality of life. And this was the parameters that was considered in the study. IOP, cup disc ratio, mean deviation all increased as the disease progressed. Duration of use and backdrops per day also was more in severe cases of glaucoma. Ocular surface disease parameters like T-Bud Schirmer decreased with the severity of the disease, and on the contrary, corneal staining increased with the severity of the disease. OSDI and GQL15 scores also increased with severe glaucoma. This was an additional finding where we compared back-free prostaglandin analogs with back prostaglandin analogs, and we found that the parameters like T-Bud, Schirmer, they increased, they were more in patients who were using back-free, and this OSDI score was also found to be lower. However, GQL15 score was independent of these factors. Coming to discussion. In my study, the mean scores for mild was 23.3, for moderate 38.3, severe it was 44.4. This was higher compared to the mother study it was done by Skalicki et al. One reason could be that they had more number of mild glaucoma patients, and the GQL score in my study was similar to that found in Skalicki et al. Study. T-Bud Schirmer test was low and corneal staining was high in severe glaucoma patients. This was similar to the studies conducted by Matthews et al. And Ramley et al. Conclusion. Prevalence of ocular surface disease among glaucoma patients is attributed to multiple drug use and the preservatives. Severe OSDI symptoms were associated with decreased T-Bud Schirmer and increased corneal staining values. Higher dose of anti-glaucoma drug was associated with poorer quality of life with increased GQL score, and there was a strong positive correlation between OSDI and GQL15. These are my references. Thank you.
You have done Schirmer's yourself, no?
So?
You have done the Schirmer test with yourself, you have done?
Yes, sir.
For the patient?
Yes, sir. Yes, sir.
You asked the patient, all the patients to close their eyes or open the eyes, and some of the patients
So,
open?
Schirmer test 1 was done. We keep the, it was done closed, and after 5 minutes we check for the values.
Okay. Thank you.
Okay, what is your recommendation for improving the quality of life of patients who use multiple anti-glaucoma medication?
Madam, we can go for back-free analogs, that is one, and we can use heavy molecular weight, artificial tears can be used, again, which is preservative-free, and this will help in improving the drug compliance.
Good morning, everyone. Title of my paper is A Prospective Observational Study on the Effect of 0.01% atropine eye drops in the Treatment of Myopia Progression in Children. Myopia, as we know, is a significant global problem, and its annual rate of progression was found to be about 50%. High myopia is associated with many sight-threatening complications. Not only is it is a cause of ocular morbidity, but also it is a source of huge economic and social burden. Also, it causes cosmetic problems due to the need for spectacles. And high myopia could not be corrected by LASIK. So, considering the above mentioned facts, we need to find an effective solution to prevent its progression. So, is there any remedy? Here comes the role of atropine, which is a competitive reversible antagonist of muscarinic receptors. Though atropine is licensed in Singapore, it's not widely used in India because it's not FDA approved. The aim of my study was to study the effect of 0.01% atropine eye drops in the treatment of myopia progression in children and to document its side effects. The objectives were to study and compare the mean change in spherical equivalent, mean change in axial length, and fundus changes between two groups, that is the group on 0.01% atropine and the group not on atropine, and also to study side effects. It was a prospective observational study conducted in the myopic children attending Little Flower Hospital OPD between November 2020 to April 2022, and the minimum total sample size was 96. Myopes above -1 diopter between 4 to 16 years were included, and myopes with other associated ocular abnormalities were excluded. After getting informed written consent and ethical clearance, the basic data of children were gathered, and their parents were asked whether the child is on atropine or not. the children on atropine, irrespective of their duration of usage of atropine, were grouped into group A. They were using 1 drop of 0.01% atropine every day at night time, and also they were wearing spectacles. In group B, the children were not on atropine, only spectacles were given for them. And at initial visit and every follow-up visit, that is every 6 months for 1.5 years, following assessment was done, that is best corrected visual acuity, cycloplegic refraction, spherical equivalent, which is calculated as spherical power plus half cylindrical power. And also fundus examination was done, side effects were asked for, and axial length was also measured. And the results were 192 eyes of 96 patients were studied, that is 96 eyes of 48 patients. Both the groups were comparable in terms of gender distribution as well as age distribution. And when we come to the mean change in spherical equivalent, it was seen that it was much higher in the group not using atropine, which was statistically significant. Also, regarding the mean change in axial length increased much more in the group not on atropine, and it was also statistically significant. But when we come to fundus changes, atropine seemed to have no much effect. And regarding the side effects, only a single child reported side effect, that was blurring cornea. Discussion. So according to my study, 0.01% atropine is found to be effective in retarding myopia progression compared to the group not on atropine, and it was the result found in ATOM 2 study also. But in LAM study, they found 0.05% as the best low concentration atropine. And when we come to the mean change in spherical equivalent, in my study, it was seen that 0.01% atropine is much better in controlling spherical equivalent compared to ATOM study and LAM study. Also regarding axial length, in my study, it is seen that 0.01% atropine is much better in arresting the increase in axial length compared to ATOM study and LAM study. So conclusion, 0.01% atropine is effective in retarding progression of myopia, but still it cannot arrest its progression. And 0.01% atropine has no significant side effects. 0.01% atropine usage should be made a routine clinical practice in India. Limitations, it was a short duration study with low sample size, and it was just an observational study, and the duration of atropine usage was different in group A. That's all. Thank you.
Last but one slide, when you told can arrest, you told no progression. In something you told, showed no. Last but one. This
slide, yes,
the
sir.
sentence.
Yes, sir.
Is effective in retarding progression.
Retarding,
still cannot arrest its progression. What do you mean by that?
fully cannot arrest progression of myopia. But compared to the group not on atropine, it is better in controlling the change in axial length and spherical equivalent. Still in the group on atropine, there is increase in spherical equivalent and axial length.
How that axial length is something retarded with the atropine? How can it reduce the progression of myopia, retarding the progression, axial length and all? How can it happen?
Sir, 0.01% atropine is better in increasing the scleral matrix. So and it retards choroidal thinning. So choroidal thinning, scleral thinning, and all controlled. So axial length.
You told scleral matrix is what happens?
Scleral matrix increase in extracellular matrix of sclera.
That means it gets thickened.
Sir, no. Thinning is prevented. So axial length.
You told choroidal thinning.
Thinning will be reduced by atropine.
Reduced?
Yes, sir.
What do you mean with 0.011%? How many milligram is there per ml? So you have told now 0.01%.
Yes, sir.
I wanted to know about the milligram in per ml. How can it be? Suppose you are asked to prepare a solution of, I'm having 1% atropine is there. I want, how to prepare? You did not, don't know. You don't know.
No, sir.
You don't know the calculations.
No, sir. Sorry.
Simple thing is what? Just multiply by 10. 0.01 multiply by 10, how much?
0.1%.
0.01 into 10, how much?
0.1, sir.
0.1 milligram per ml, that's all. That means you must prepare solution 0.1 milligram per ml.
Okay, sir.
Understand now?
Okay.
Any question?
How long you are planning to give atropine for these children?
Ma'am, until 16 years we are giving, then we look for progression. If there is more increase in axial length than spherical equivalent, then we will have to give them again, or else we can stop. At every visit we are checking axial length and spherical equivalent.
So this was done after 1.5 years study?
Yes ma'am, 1.5.
Okay, do you expect any rebound effect once you stop the atropine?
Actually, in my study, I have not stopped for anyone, but in literature, they are saying there is rebound effect for 0.01% atropine. Thank you.
Good morning, respected judges and other delegates. I am Dr. Sri Lakshmi from Jubilee Mission, here to present about ocular toxicity of daily anti-tubercular treatment regimen, a prospective observational study. So India carries a significant burden of tuberculosis, which is the commonest cause of infectious disease-related mortality. Anti-tubercular drugs are among the commonly used drugs which can cause serious ocular toxic effects. Since anti-tubercular drugs are given in combinations, it is difficult to delineate which drug is causing more ocular side effects. This is a revised National TB Control Program daily fixed drug combination regimen, which is currently followed, which involves 2 months of intensive phase and 4 months of continuation phase. In contrary to the previous regimen, ethambutol is used throughout continuation phase also. So, toxic optic neuropathy are a group of medical disorders which can be defined as visual impairment due to optic nerve damage by any toxin, and anti-tubercular treatment induced optic neuropathy is of the toxic type. Aim and objectives of my study: to study the changes in visual parameters in patients on ATT, to analyze the OCT-ONA changes in patients by taking RNFL measurements once before the initiation of treatment and once during the ongoing treatment, any time between 3 to 6 months. Study design is prospective observational study set in Department of Ophthalmology and other departments in a tertiary care hospital. Sample size 26 study subjects. Inclusion criteria: all patients with microbiologically confirmed and clinically diagnosed active pulmonary and extrapulmonary tuberculosis before starting the regime and while on regime, males as well as females between 18 to 60 years of age group, OCT signal strength more than 6/10. Exclusion criteria include pre-existing optic neuropathy or retinal pathologies, media opacity other than incipient cataract, pre-existing visual field defects and color vision anomalies, history of taking any other non-anti-tubercular drugs known to cause ocular toxicity, glaucoma patients and anti-tubercular treatment dropouts. My methodology: patients were subjected to detailed ophthalmologic evaluation once before the treatment and once during treatment. Visual acuity is done using Snellen's chart, which was later converted into logMAR chart. Color vision using Ishihara's chart. Slit lamp anterior segment evaluation and fundus evaluation using 90D lens. OCT average nasal, temporal, superior and inferior RNFL measurements were noted. Mean age of the study subjects were 42 plus or minus 13.71. Out of 26 study subjects, 9 were females and 17 were males. So visual parameters were studied in 52 eyes of 26 subjects. No significant change was observed in visual acuity and intraocular pressure during my follow-up period. Using paired t-test, significant RNFL thinning was detected in superior, inferior and temporal quadrant. No significant change was detected in the nasal quadrant. So this is a graph plotting the RNFL thickness, in which we can clearly see the RNFL thickness has reduced during treatment period. So this is a OCT of a patient prior to initiation, and following initiation we can see thinning in different quadrants. So red-green color vision defects were also observed in 8 out of 52 eyes. My observations: despite a near normal appearance of the fundus on ophthalmoscopy, OCT clearly demonstrated and quantified the loss of retinal nerve fibers from the optic nerves. Based on the study, among 26 samples, statistically significant thinning was observed in superior temporal and inferior quadrant. However, RNFL changes in nasal quadrant was not statistically significant. Red-green color vision abnormalities were noted in 8 out of 52 eyes, and identification of color plates tended to be worse in patients with thinner temporal quadrants on OCT RNFL analysis. Visual acuity and intraocular pressure did not show much significant change. Asymmetric loss of nerve fibers were also noted from both the eyes in majority of study subjects. Discussion. Retinal thickness can be measured for early detection and diagnosis of retinal pathologies. And OCT, which is a non-invasive method, has been extensively used to quantify RNFL defects in patients with antitubercular treatment-induced toxicity. So in a study conducted by Zollmiller et al., considerable loss of fibers from all the quadrants, especially temporal fibers, were seen, which is consistent with our study. As Kumar et al., thinning of RNFL is seen after 2 months of ATT compared to the baseline values. Yogyukum et al. In that OCT, they showed that OCT may be helpful in follow-up of patients with toxic optic neuropathy. And our study showed OCT changes appeared before the fundus changes, so it is definitely helping in follow-up of patients with toxic optic neuropathy. SM Konakorden et al. Showed out of 40 eyes receiving ethambutol, color vision was defective in about 35 eyes, while in our study only 8 out of 52 eyes showed color vision abnormalities. Since RNFL thinning can be detected before the appearance of clinical symptoms, it helps in early detection, follow-up, management, and it can help in preventing permanent visual damage. It is imperative to create awareness about the oculotoxic effects of antitubercular drugs so that periodic screening can be done in patients undergoing antitubercular treatment. Limitations is small sample size and number of follow-ups were limited. These are my references. Thank you.
Thank you. Will you please show that OCT picture again?
Yes.
Both sides, you have shown. Yes. That is normal.
Yes, sir. This was taken before the treatment.
Okay. Yeah.
Then after undergoing ATT, post 3 months, it showed significant thinning of RNFL.
Which quadrants you have written, no?
Yes, sir. In the left eye, temporal quadrant, right eye, superior, temporal and inferior quadrant thinning is seen.
Okay. Okay, thank you, ma. Thank you.
Changes?
Ma'am, visual acuity, among the sample size, it was not seen statistically significant, but those patients who were complaining of defective vision, when we checked the OCT, they had more RNFL thinning when compared to the other subjects.
So what is your line of follow-up when you find RNFL changes in those patients?
If RNFL thickness is seen to be reduced, we
you stop it?
Yeah, we asked to change the drug, ma'am, ethambutol. We asked to change the drug from the fixed drug combination. We asked to change the drug to other less toxic drugs.
After
so
that,
we follow up in the pulmonology department and we change the.
After the less toxic drug has been introduced, what happened to the nerve fiber layer, thickness and all?
What's that?
You have stopped the drug.
Huh.
You have started some other drug.
Yes, sir.
Have you followed the patient afterwards?
Not all patients I was able to follow up.
Did they show any improvement or arrest of that particular changes?
Sir, some patients it showed improvement, not improvement like very little improvement and or arrest. But in some cases in the previous studies which I have referred, they have told sometimes even after stopping the drug there can be worsening of the toxic effects. Okay,
thank you.
Good morning. My free paper is titled Vision-Related Quality of Life in Patients with Diabetic Macular Edema who are receiving intravitreal ranibizumab injection at a tertiary eye care hospital in Kerala. So among the various causes that contribute to a defective vision in patients suffering from diabetic retinopathy, diabetic macular edema has been identified as the most common cause, and various molecules have been implicated in its pathogenesis, of which the vascular endothelial growth factor is found to be the most predominant. Various treatment modalities are available, starting with laser photocoagulation, but now the mainstay of management is the use of the intravitreal anti-VEGF agents. The rationale behind the study was that many times the effectiveness of the intervention is assessed from the clinician's point of view based on the changes in the visual acuity and the changes in the macular thickness that is seen on the OCT. But this necessarily does not need to translate for a patient's satisfaction or an improvement for the quality of life for the patient's point of view. And also these injections are highly costly and many patients don't prefer to take a repeat injection. So I wanted to study a subjective quality, that is vision related quality of life in an objective manner, do a statistical analysis and see if whatever results we are getting, whether improvements or not, they are statistically significant or not, and no similar studies were done in Kerala. So the primary objective was to get a measure of the overall composite score for the vision-related quality of life pre and post injection. And secondary objectives was to compare those various subdivisions that contribute to the vision-related quality of life. It was a hospital-based observation longitudinal study done at a tertiary eye care hospital in Kerala, with my study population being patients who were diagnosed with diabetic macular edema and admitted for the intravitreal ranibizumab injection, from which patients were taken consecutively. The inclusion criteria was that they had to satisfy the definition of diabetic macular edema as given by the American Academy of Ophthalmology and admitted by their treating ophthalmologist for the injection. Patients who had received this injection prior, as well as having other ocular pathologies which could interfere with their vision-related quality of life, were excluded from the study, and I had 40 patients for my study. So my study started with a baseline recording of the demographic data as well as recording details that were pertaining to the disease, followed by a detailed ophthalmological examination starting from the visual acuity up to the posterior segment fundus examination, as well as measuring their baseline OCT thickness, the central macular thickness on the OCT. And following this, I used my main tool for the study, which was the National Eye Institute Visual Function Questionnaire 25. And I administered the same questionnaire on the day prior to the injection and repeated the questionnaire at week number 2, 6 and 12 weeks post-injection. So my results were as follows. I had 40% males and 60% were females in my study, of which 55% were aged more than 60 and 45% were in the age group of 45 to 60. 40% received it in the right eye and 60% in the left eye. Looking at their OCT macular thickness, their baseline thickness, 31% are in the range of 600 to 700 micrometers, 28% were in the range of 500 to 600, 22% in the range of 400 to 500, and the rest 19 in the range of 300 to 400. Looking at the type of diabetic retinopathy among the patients that were a part of my study, 35% had severe NPDR, 33% had moderate NPDR, 7% had mild NPDR, and 25% had early PDR features. So this was my primary objective, which was analyzing the mean composite score. The questionnaire basically has a scoring method from which you can give a total score for the patient, which gives you an index of how much is their vision-related quality of life. So my x-axis shows 4 values, 1, 2, 3, and 4, 1 corresponding to the baseline, 2 corresponding to the score at 2 weeks, 3 corresponding to the score at 6, and 4 corresponding to the score at 12 weeks. And mathematically an improvement in the value was seen, and on statistical analysis also it was significant with a p-value less than 0.05. Similarly, a few of those subscales of vision-related quality of life were also analyzed, and they also showed similar statistically significant improvements post the injection at 2, 6, and 12 weeks. This was for the mean general vision score. This was regarding the mean distance activity score during the study period, the near activity score, then social functioning score, the mental health score. Coming to the discussion, my primary objective was to assess that overall composite score, and that showed an increase in value of 12.9 at 3 months, which was statistically significant. Similar studies which were done elsewhere also showed statistically significant improvements in the vision-related quality of life, as the study done by LF Beto, where the composite score increased by 6.3 at 6 months, and the Ride and Rise study also, where it increased by 10.9 at 1 year. Similarly, my study also showed that all subscales showed an improvement over the study period, which was also, but in the LF Beetle study, the main subscales that improved were the distance vision and the near vision. So the conclusion was that the diabetic macular edema does cause a great burden prior to any intervention, and which is statistically significantly showing an improvement in the vision-related quality of life post-injection. And these improvement was seen not only in the overall composite score, but even among the various sub-faculties that contribute. And so this shows that a single injection itself can bring about a great improvement and reduce the burden of the disease for these patients. And these are my references. Thank you.
What is the dose of ranibizumab you have used?
So 0.5 mg, sir, in 0.05 ml.
Point?
0.5 mg, 0.05 ml, sir.
0.05 ml. Did you find any complications after ranibizumab injections?
No, sir. So injection-related complications, no, sir.
So no development of endophthalmitis and all?
No, sir. No, sir.
Sure.
Yes, among my study patients, I'm sure, sir.
I say in your study you have not.
Sorry, sir.
In your study you have not got anything.
No, sir. No, sir. No complications.
Well, actually, ranibizumab study, so many studies were there. What's the significance of your study here?
Sir, I wanted to look at the quality of life, sir. So, like, is it that injection is so expensive? Many patients in my setup also have come from a government college, sir. They don't opt for a second injection or a third injection. So that one injection itself causes a lot of economic burden. So is that really?
Suppose it again the problem increases, will you advise another injection or not? Because it has been told, no, at least once in a month, you have to at least 3 injections,
Yes,
something
sir.
like that.
So the regimen states that we have to give it on a monthly basis for at least 3 months and then decide, sir. But if improvement is seen, sir, I would definitely ask for a repeat injection if the first
That
injection
means
happens.
patient have to pay or government is providing free?
So my setup, sir, patient has to pay, sir.
In your hospital?
Yes.
It's government, no?
It's government, but the injection is bought by the patient, sir.
You are allowed to do that? Did you get permission?
Sorry, sir.
Did you get permission from others and all, from higher authorities?
Yes, sir. So, like, patients are generally admitted, sir, in the hospital, and the routine is like that, sir. They usually, even for not only my study, but for routine treatment purposes, the patient actually purchases the injection and it is being given at the hospitals.
No complaint, nothing. Nobody has complained. Achha, very, very nice. Okay, ma'am.
So, you have given injection only in one eye or both eyes?
So one eye.
Only in one eye. Better eye or worse eye?
The worst eye.
Worse eye. And what was your observation after 3 months?
Sorry, madam.
What was your observation of central retinal thickness after 3 months? Was it increasing? Because you are giving only one injection and observing after 3 months.
Yes.
So, was there any reduction in central macular thickness or
So, not all patients, but many of the patients did show a reduction in their central macular thickness, sir.
Which college, man? You?
RIO Trivandrum.
Trivandrum.
Good morning, everyone. I would like to present my study on the correlation of different grades of visual acuity more than equal to 6/12 with contrast sensitivity and stereopsis in patients with primary open-angle glaucoma and ocular hypertension. Despite their normal or near normal Snellen visual acuity, patients with glaucoma often complain of poor vision. This study was conducted to understand the symptoms better and help in developing vision assessment to monitor patients in the early course of the disease. My objectives of the study were to determine the correlation of different grades of visual acuity more than or equal to 6/12 with contrast sensitivity and stereopsis in patients with primary open-angle glaucoma and ocular hypertension, to compare the contrast sensitivity among POAG and ocular hypertension, to compare stereopsis among POAG and ocular hypertension. Coming to my methodology, it was a study design. It was a hospital-based cross-sectional study done at the glaucoma clinic of Tertiary Care Eye Hospital in South Kerala. And the study period was 1 year. These were my inclusion and exclusion criteria. The sample size was calculated based upon the study by Stephanie Lin et al. And it came to be 109. The study variables were socio-demographic variables, visual acuity, visual field index, mean deviation, monocular contrast sensitivity, and stereopsis. After getting an informed consent from patients who fulfill the inclusion criteria, a detailed ophthalmological examination was done. Corrected distance visual acuity with Snellen's chart at 6 meter was done and converted to logMAR value. Slit lamp biomicroscopy was done with a plus 90D lens and gonioscopy was done. Visual field of the eye was analyzed using Humphrey Field Analyzer 24-2 program. Monocular contrast sensitivity was measured by Pelly-Robson contrast sensitivity chart at 1 meter. Binocular stereopsis testing was done by Titmus test at 40 centimeter. Coming to my results, majority of my patients, 64.2% were having primary open-angle glaucoma and 35.8% were having ocular hypertension. Majority of my patients came under the age group between 51 to 60. Majority of my POAG patients were females and majority of my ocular hypertensive patients were males. Distribution of visual acuity in logMAR units. Majority of my POAG patient had a visual acuity of 0.2 in logMAR units, and ocular hypertensive had a visual acuity of 0 in logMAR units. Distribution of monocular sensitivity, contrast sensitivity. Majority of my POEG and ocular hypertensive patients had a monocular contrast sensitivity in the range of 1.5 to 1.8. Majority of my patients had a stereopsis in the range of 101 to 400 seconds. Correlation of the visual acuity with contrast sensitivity and correlation of visual acuity with stereopsis did not give a significant relationship. MD value correlation with visual acuity in primary open-angle glaucoma gave a non-significant large positive relationship. Visual field index with visual acuity in primary open-angle glaucoma showed a non-significant relationship. In my study, comparison was done using unpaired t-test and comparison of contrast sensitivity among POAG and ocular hypertension and comparison of stereopsis among POAG and ocular hypertension. The difference came to be not statistically significant. However, significant association was found between stereopsis and contrast sensitivity in POAG and between stereopsis and contrast sensitivity in ocular hypertension. That is, those with decreased contrast sensitivity had decreased stereopsis also in both POAG and ocular hypertension. Coming to my discussion, my study consisted of 109 patients with 70 POAG and 39 ocular hypertensives. In my study, visual acuity more than or equal to 612 did not show a significant correlation with contrast sensitivity and stereopsis. In a study by Amal et al., stereo acuity significantly decreased in early glaucoma, and in a study by Hawkins et al., reduced contrast sensitivity was found to be significantly correlated with good visual acuity, and compared with visual acuity, the disease process preferentially affects contrast sensitivity. In my study, 25.7% of patients with POAG had a contrast sensitivity of less than 1.3 units, and 28.2% of ocular hypertensives had a contrast sensitivity less than 1.3 units. 5.7% of POAG patients had stereopsis less than 40 seconds, and no ocular hypertensive had a value less than 40 seconds. In my study, there was a significant association between contrast sensitivity and stereopsis. That is, patients with decreased contrast sensitivity also had a decrease in stereopsis in both POAG and ocular hypertension. This was similar to other studies done by Stephanie et al., who said that the vision in glaucoma is a multidimensional construct and the contrast sensitivity and stereo acuity correlated with each other. Study by Jess Richman et al. Showed that the aspects of visual acuity that predict ability of a patient with glaucoma to perform activities of daily living are visual acuity and contrast sensitivity. To conclude, in my study, there was a significant association between contrast sensitivity and stereopsis in both POAG and ocular hypertension in those having good visual acuity. However, correlation of visual acuity more than 612 with contrast sensitivity and stereopsis was not found to be significant. This can be attributed to the fact that my sample size was small, study was clinic-based, and the study subjects need not have been a representative sample of the population. Hence, I would like to conclude that the vision assessment in glaucoma should be not only based upon visual acuity, but also based upon contrast sensitivity and stereopsis. These are my references. Thank you.
So you have selected the samples size, or the statistician have done?
Statistician have done, sir.
You know how to calculate and all?
I asked a statistician, sir. He told me how to calculate based upon that value. Based upon the formula,
you are told now contrast sensitivity as well as stereopsis are reduced in POAG as well as ocular hypertension. Yes. Significance is there. The treatment was started for ocular hypertension cases or not?
It was not started, sir. For
not
POAG
started.
Patients,
you started.
It was started.
What
ocular
about ocular
hypertensive patients were on just lubricant drops only. They were on
ocular hypertension study report you studied.
Yes, sir.
You have not done as per ocular hypertension study report. Did you start or not?
No, sir.
The
it
treatment
was not started. Visual field effect was not there.
No, ocular hypertension study report says better to start the treatment if you have got a value of 24 and above.
Yes, sir.
We were intraocular hypertension means you have mentioned which IOP you have taken as ocular hypertension.
Range, sir.
You
More
have
than
taken
21, sir.
21. Anyone about 24, 25 and all?
Up to 25 I had taken, sir. My sample size patients had that. Up to 26.
So 26 means you would have started treatment then.
No, visual field progression was checked.
No. This is a study report. You have studied or not? Ocular hypertension study report.
No, sir.
You have not heard?
No.
Better read that also, no? Okay.
So how do you account for that decrease in contrast sensitivity in ocular hypertension?
Even in ocular
And what is the relevance of finding this decrease?
Even in ocular hypertension, madam, the optic nerve fibers are getting damaged, and this may not correspond to visual acuity, but in contrast sensitivity, we can pick up it early. That is, optic nerve damage is occurring. We can.
So you start treatment once you find decreased contrast sensitivity in patients.
We have to start treatment ideally, but we need a larger study, and we need to analyze more number of patients also.
Why waiting for larger study, man? See, already problem is there. Why do you start that? Why can't you start the treatment? Otherwise, at least you can do.
You have heard about ocular hypertension treatment study, no?
Yes, madam.
Yes.
She has not studied that.
Not studied.
You just study all the glaucoma study reports.
Okay.
So all the glaucoma study reports, all the optic neuritis treatment trial, everything, diabetic study reports. For a PG, it's a must.
Any patients had cataract in the study?
Patients with significant cataract were excluded in my study, madam.
Were excluded.
Excluded.
Okay, thank you.
Thank you, ma'am.
Good morning. I'm here to present my study titled Clinical Profile of Acute Primary Angle Closure Glaucoma After Laser Peripheral Iridotomy. Glaucoma is the second leading cause of blindness in the world, and in India accounts for 11.2 million, of which primary angle closure glaucoma accounts for 2.54 million. Acute primary angle closure glaucoma is a vision-threatening emergency, and it is a major cause of glaucoma blindness globally. Objective of my study is to study the socio-demographic and clinical factors affecting the outcome of laser peripheral iridotomy in patients diagnosed with acute angle closure glaucoma. Methodology. The study designed was a hospital-based prospective observational study. It was done in the OPD and casualty of Tertiary Care Eye Hospital, South Kerala. And study population it included patients presenting with acute angle closure crisis in the OPD or casualty. The sample size calculated was 40. And my inclusion criteria includes patients more than 40 years of age and who were diagnosed with acute primary angle closure attack, and patient willing for laser peripheral iridotomy, and patient willing to give consent. Exclusion criteria include bilateral acute primary angle closure attack, secondary angle closure, chronic angle closure glaucoma, previous intraocular surgery, and reported history of pre-existing glaucoma at the time of acute primary angle closure, and incomplete clinical data of patient not willing to give consent. A data collection tool, Proforma was used to obtain the patient details, and Snellen vision acuity chart was used to assess the vision of the patient and wet retinoscopy, and Goldman applanation tonometry was used to measure the IOP, and slit lamp examination was done to visualize the anterior segment of the patient, and gonioscopy with Goldman 2 mirror was used for assessing the angle status of the patient. Study variables, socio-demographic variables, best-corrected visual acuity, refractive error, anterior chamber status, intraocular pressure. All these were assessed at the time of presentation at 2 weeks, 1 month, 2 months, and 3 months. The results of my study. Percentage distribution of angle according to the age. About 60% of the patient was at the age group of 51 to 60, and 85% were females. 60% had hypermetropic refractive status of the eye. On assessing the best corrected visual acuity of the patient in logmark unit, before the treatment, 87.5% of the patient was between 0 to 0.3 logmark unit, and after 3 months of study, 95% were, initially 87.5 was between 0.3 to 0.6 logmark unit, and at the end of 3 months, 95% were having visual acuity between 0 to 0.3. And IOP, effectiveness in intraocular pressure, before the treatment, 87.5% of the patient had IOP between 31 to 40, and after 3 month period, about 87 had an IOP less than 20. It was clinically significant. Angle status of the patient. Angle status before the treatment, all 100% of the patient had an closed ankle, and at 3 month period, about 82.5% of the patient have an angle opened in 3 quadrants. Then percentage distribution of anti-glaucoma medications, majority of my patient had to take, 75% of the patient had to take 2 anti-glaucoma medication. Outcome of my study, I have assessed the ideal outcome of my study was the patient just has to use laser PA and his IOP without any medical therapy. His IOP was less than 21. The desired outcome was with laser PA he had to use a medical therapy to decrease his IOP less than 21. And a failed outcome was the laser PA with medical therapy, but IOP was more than 21. So 85% of my patient had a desired outcome. Discussion. In my parent study, Lee et al., a successful IOP control was seen in 59.7% of the patient after laser PI, and the mean age group was 66 in that study, and 76% were female, and the mean IOP was 52.6 millimeters of mercury. In my study, IOP control was obtained in 87.5% of the patients, and the mean age group was again 51 to 60, 85% were female. And the IOP was between 31 to 40 in 35 out of the 40 patients at the time of presentation. And in Andretta et al., the best corrected visual acuity was at 6-month period was 86% were between 0 to 0.3 log mark. And again here the 76% were female and mean age group was 69 and the mean IOP was 53. In my study, the best corrected visual acuity at 3 months was 95% between 0 to 0.3 log mark. And the mean age group was 51 to 60, and 85% were female, and 35 out of the 40 have IOP between 31 to 40 millimeters of mercury. And Jovina Ellis et al. Study, here also their successful treatment with laser PI was with 42 to 72%. In my study, it was 87.5%. In conclusion of my study was that the laser peripheral iodotomy following an acute angle closure attack along with anti-glaucoma medication when done promptly is able to control the intraocular pressure and improve the visual acuity and thus control the burden of the disease. These were my references. Thank you.
I think you mentioned something about 31 to 14 or something.
Age group, sir.
Age group. No, something IOP control.
IOP, yes, sir.
31 to 14. 31.
Yes, sir.
31 to 14.
40.
40. 40.
40, yes, sir.
That is.
Majority of my patients before treatment were between 31 to 40.
Oh, after giving PI?
After laser PI, majority had IOP less than 20.
Less than 20. Anyone above 25 or something? Remaining?
Yeah, there were patients, sir.
For them, what did you do?
Anti-glaucoma medications were given to control the IOP. And if it was not controlled, then surgical treatment was advised to them.
It would have been open angle glaucoma also, no?
Oh, it
combined
could be
glaucoma.
combined open angle glaucoma. Anti-glaucoma medications was used for 75% of the patients.
What drug you have used?
Sir, Doxox and Timolol was used, 2 drugs.
What?
Dorzolamide and Timolol.
Dorzolamide. Achha. And Timolol.
Timolol, 2 drugs.
Both are having same decreasing secretions. Why do you want to combine both?
Yes, sir.
See, Dorzolamide also decreases secretion.
Yes.
Timolol also decreases secretion. Why do you want to combine a 2 drug which can
have
got the same effect?
No, some were using Timolol alone, some were using Doxox.
Achha. Okay.
Any optic disc changes or field changes observed in any of these cases?
No, madam. Majority of the patient does not have any optic disc changes. Field changes was there in 12.5% of the patients had a moderate field change.
What type of field defects?
Moderate field change was there, ma'am. Small scotomas.
Without any changes in the disc?
Yes, madam.
Thank you very much. Very nice session we had and fantastic papers were presented. Thank you very much.